So treatment, you can always start with pharmacological treatment. Pharmacological treatment means using medication. And what are the medications that we have? I think the most common and the most popular one everyone knows is the blue pill. That is called Viagra, is the generic name, of course, and it's actually sildenafil. It comes in various doses. There is 50 and 100 milligram dose. There are other drugs in the same category as well, tadalafil. There are various drugs in that category as well, with different doses. And now they even have drugs that can generics from which are cheaper than what it was. So a lot of physicians would be a little bit apprehensive to start these medications right away if they don't know what your baseline cardiovascular risks are, if you have a disease, and what your blood pressure is. So that's something that needs to be monitored and taken into account. So
because of the side effects, right?
Correct, absolutely. So these drugs have their own side effects, cardiovascular side effects, and if you have an underlying ischemic cardiac disease or very badly controlled blood pressure, these should be contraindicated. So among the drugs in this group, it's called the PDE5 inhibitors. There are phosphodiesterase inhibitors. So there are no comparison that is done between the superiority of each drug. So they're all pretty much the same, and depends on whether it suits you or not. So that's the first step. And of course, besides having side effects of cardiovascular risks that these drugs carry, they also have other risks like a headache, flushing, dyspepsia, which means a tummy upset, a nasal congestion, and some can even have a little bit of muscular pain called myalgia.
When we take these drugs, right, it's just can we say a quick fix? We're not really solving the problem or getting full treatment that we should.
What these drugs do is to make sure that you can get an erection and to have intercourse. You're absolutely right by saying it doesn't fix the underlying problem. It is a remedy for the problem that you already have. So once we've started these pharmacological drugs, what comes next is the non-responders. We talk about non-responders. So how many percent would respond? We can here say about 50% to about 60-70% can respond to medication alone, but non-responders are people with failure to have sexual stimulation, failure to use an adequate dose. They want to wait and not just consume the drugs. There are other methods that we can use, and alternative therapies such as the vacuum erection devices can be used. A mechanical device or a battery-operated device that predates, intercourse. Just used about a few minutes before intercourse. Once you get the rigidity, then you can have your sexual intercourse, and then automatically, you have flaccidity after intercourse. The other newer techniques for erectile dysfunction, something called extracorporeal shock wave therapy. So this actually is a shock wave in low intensity that is given to the penis itself to improve the blood flow. As you know, one of the biggest causes of erectile dysfunction is blood flow related. So shock waves given in 6 cycles or 12 cycles have shown to improve this blood flow. So that's actually helpful for a certain group of patients as well. So that's been shown to help.
Is it painful?
Well, the intensity is a low intensity. So you do have some discomfort. A local anesthetic is given, and some patients can also have an intravenous analgesic or a painkiller given to them as well. So that can help alleviate the pain. And the intensity changes depends on whether they can tolerate the shock wave.
But it's better than the penile injection, right?
Oh, and that was what I was going to come to. It is daunting. It is definitely daunting to see a big needle traversing the penis. That's something second line, and it's actually called an intracavernosal injection. So that is done just before you want to have sexual intercourse. Injection is given into the cavernosa, and you can induce an erection that way. Some drugs like alprostadil, for example, are given intraurethral. So just where the urethral opening is, you actually introduce this drug, and that can also induce an erection just before intercourse. So there are various methods in second line. Of course, not forgetting each one carries its own side effects like pain, prolonged erection, a priapism is something that an erection lasting more than 4 hours, and penile fibrosis if you have injected various times at the same site. Combination therapies are also something that can be given as second line. Pentelamine, a drug called pentelamine, piperacillin, not very commonly available in our setting here. It can improve, efficacy as well if given as a combination. Topical agents are something that you apply on over the shaft, and alprostadil can be given as a topical agent as well, but the success rates are not very high. So we spoke about injectables, the Cavajet. There's a lot of dropout rates in that, and of course they don't prefer, they don't want to see a big needle, and then you have the side effects that follow. Then there are the third line therapy. So everyone who's exhausted the medical therapy, lifestyle modification, who's tried all these other techniques, and they've just said there's no other way but to have surgery. Surgery is penile prosthesis. So that is two different types of devices available. One is the inflatable device, 2 or a 3-piece inflatable device, or one is a malleable device. So two main sites or approaches. One is penoscrotal and the other one is infrapubic, and I think it's very technical to go through the surgical aspects, but both provide good resolution, and I think satisfactory in about 90 to about 95% of patients.
I mean, just listening to all that just to get an erection. I mean, it's no wonder why people will go for the pills, right?
Yeah, the easiest way to to deal with it is, of course, pharmacological, taking a drug. But it's just sad that not everyone has the same effect, and not everyone can get the effect that they want, really.